Now we are going to discuss that how the bradykinin cause the increased vascular permeability, right? So this is going to be the second effect that caused by the bradykinin. So you have to first understand what is the permeability, right? So permeability means out that how easily things can pass through a barrier, right? A permeable membrane let things through, right? So an impermeable membrane doesn't allow anything to move out. So the increased vascular permeability means out that the blood vessel wall becomes more and more leaky now, right? Things can pass through them very easily. So fluid can also now escape from the blood vessel into the surrounding tissues, right? So that escaping fluid, that we call it up as the edema, right? And this edema ultimately causes up the swelling into the patient, right? So how does the bradykinin do this, right? It again starts with, okay, the same B2 receptors, right? The B2 receptors are causing the same calcium rise, right, by the help of going into the endoplasmic reticulum, right? And this rise into the calcium in the endothelial cells, you have to remember it out that this time, instead of activating the nitric oxide synthase, right, this time, this increase in the calcium, rather than activating the nitric oxide synthase, this activates another protein known to be as MLCK. What is this MLCK? This MLCK means myosin light chain kinase. Okay, so myosin, everybody got to know that there is a protein, right, together with the actin, and this helps out to form the contractile machinery of the muscles, right? Okay, and so kinase is also another kind of another kind of, you can just say that, phosphate group, right, which adds to the protein to activate that. Okay, another thing that you can now remember it out, another thing that you can remember now, that whenever we do have the production of the MLCK, right, this adds the phosphate. This MLCK adds a phosphate to the myosin light chains, right? And this causes the actins and this causes the myosin inside the endothelial cells contract. Okay, the contraction happens out just like the muscle contracts, right? So now here is the point that the endothelial cells are connected to each other like a brick wall. Endothelial cells are being connected to each other just like the brick wall, right? And so what is going to happen out? Once we do have the contraction over here, right? And they do have very tight junctions right in between to these ones, right? And whenever we do have the contractions, right, or we can just simply say that when the actin and myosin inside these cells, they do contract, the cells pull away from each other, right? And they become smaller and they become a little bit rounder, right? They become smaller than before and rounder, right? And this contraction actually creates some of the gaps that you're looking at over here with the purple color, right? And so the adjacent cells, they do get some of the gap. And so these gaps, just like you can consider like the holes opening up in the wall of the blood vessel, and through this gap, the fluid, the proteins, which are normally trapped into the blood vessels, can now leak out into the surrounding tissues. Okay, and this leakage, because of the contraction, this leakage definitely causes of the swelling, right, which we clinically call edema, right? So to summarize all this time, bradykinin raises the calcium as we discussed, but this time they act on the MLCK. This MLCK means out the myosin light chains, and ultimately this led the cells to get smaller, rounder, contract, right? And the edema happens out. Okay. Now we got to understand that how bradykinin causes the pain, right? This is the third effect which is being done by the bradykinin. So bradykinin, do remember, bradykinin does not cause the pain by acting on the blood vessels. Okay, bradykinin does not cause the pain by acting on the blood vessels. Instead, it directly acts on the nerve endings. It is actually acting on the nerve endings, right? And what are those nerve endings means out? That specifically this starts binding the receptors on the ends of the sensory neurons, right? And you see that the sensory neurons are the special nerves that helps you out to detect the sensations like the touch, the temperature, or the pain, right? So whenever the bradykinin binds to the sensory nerve endings, it activates one of the channels known as TRP1, the transient receptor potential vanillide 1, right? I will try to provide you the notes as well so that while looking over the lecture, you don't worry to write it down. So now let's first understand about this one that once this TRP1, right, this starts getting activated. Okay, let me reframe. When the bradykinin, it binds to the sensory nerve endings, it start activating one of the channel known as the TRP1, right? Once we do got this TRP1, what happens out? This also, this definitely directly or indirectly, we can say being activated by the bradykinin, right? So whenever the bradykinin binds to its receptor, this triggers out one of the another chain reaction, right? This also begins out to have another chain reaction and starts opening up its channels, right? So when this channel is opening, this allows the sodium ions, okay, and this allows the calcium ions, which are the positively charged ions, to rush into the nerve cells, okay. These gets into the nerve cells. Once been into the nerve cells, right, from the outside, what is going to happen out? The outside of the cell has a higher concentration of the sodium. So when the channel open, the sodium flows inward, right? So this influx of the positive ion changes the electrical charge inside the nerve cell, right? And normally the inside of the nerve cell is negatively charged compared to the outside. So when the sodium rushes in, the inside of the cell become less negative, and this less negativation we usually call it as the depolarization, right, as we have just learned previously too. So when the depolarization less negative, right, which is up to the depolarization, once it's been depolarized, right, and this depolarization reaches to a certain threshold, what has happened out? It starts acting the action potential, of course, right? This action potential is fundamentally, essentially important, right? Just like to travel along the nerve fiber of the spinal cord and all the way to the brain, right? So when the brain receives the signal, okay, it interprets as a pain. This causes the pain, right? So we can just simply say that the bradykinin directly excites the pain sensory nerve endings and that sends the pain signals to the brain. So there's one more important point to discuss, that bradykinin also sensitizes these nerve endings, right? It means that sensitization makes or make it up more responsive to the other stimulus, right? For example, we do have prostaglandins. We do have prostaglandins, right? And these are also produced during the inflammation, okay? So they also work together with the bradykinin, okay, to lower the threshold for the firing. So this means normally the harmless stimuli like a light touch or the gentle pressure can also now trigger the pain. So this is why inflamed tissues are so tender and painful, and this painful and tenderness this painful and tenderness is also known as the hyperalgesia, ALGESI, which means that the person is now more sensitive to the pain, right? Or you can just say that the increased pain sensitivity into this one, right? So all these three mechanisms are important to understand that how does the bradykinin causes the increased vasodilation, increased vascular permeability, and the pain, okay? And another or the fourth component of the kinin cascade was the C1 esterase inhibitor. Very briefly, let me just tell you that these are acting just like the inhibitors, right? Inhibitor of the kallikrein. So you see that if we do apply the C1 esterase inhibitor to the kallikrein, all this pathway gets worse. Yes or no, right? It is very much obvious. You have to remember it all. And so, what if we do have the deficiency of this inhibitor? What if we do have the deficiency of this inhibitor? Or any genetic mutation happens out, so we do have the low levels in the body for this C1 esterase inhibitor. what will be happen out? Of course, this will kept on making the bradykinin, and the person will having the more and more vasodilation, the increased permeability, and more sensitivity to the pain, right? And causing the edema in the patient, right? Uh, Remember the concept that how the endothelial cells they start getting rounder, smaller, right? And they do guard the fluid to travel, right, into the surrounding tissues, right? This sort of edema which develops because of this condition, right? This is known as, or you can just say that because this edema is caused by the bradykinin accumulation, right? So this edema is known as angioedema. Angioedema, right? And so you have to remember it out that the inhibition, if the deficiency of C1 esterase inhibitor, right? The deficiency of the C1 esterase inhibitor can cause the angioedema in the body. If they do ask why and how, you can just tell them this similar pathway of the bradykinin, and this is because of the bradykinin, right? After that, we do got another concept to learn that is about another system, which is the fibrinolytic system. Okay, so now over here you have to remember it out, the fibrinolytic system. Before we get into this one, you see that we do have one of the D dimers being over here, right? Okay, let me first tell you what is the D dimer, right? This is also very commonly ordered blood test. Okay, do usually order one of the blood tests for the patients, which is normally as the D dimers, right? And especially your emergency departments, right? We do whenever we do suspect any of the blood clots or anything else like that, we do prefer this test to be done, right? But what to understand first, what is the D dimer? We need to first understand a little bit how the blood clot forms, right? And how they are broken down. We have learned until now, let me just recap very quickly that whenever you get injured, right, your body starts forming a blood clot to stop the bleeding, right? This process is known as coagulation that we have just discussed. And so the final step of the coagulation is the conversion of the fibrinogen into the fibrin monomers, right? What is fibrinogen? This is a soluble protein, right? Meaning it dissolves in the blood and usually being produced by your liver, right? Circulate in your plasma. So when you get injured, an enzyme called thrombin, this we discussed, right? This is starts getting activated. The thrombin acts on the fibrinogen and converts that into the fibrin monomer, and ultimately we develops the fibrin mesh so that uh, all of this mesh helps out to form a table plot, right? So now we have to remember it out that how does these blood clots are broken down? Okay, this broken down of the blood clot that is actually been done by the fibrinolytic. Okay, and over here, one of the key enzyme that everybody should remember that is that let's say that whenever you got the injury and the injuries now start healing, right? Everybody got to know the process of the healing. Everybody got to observe the process of the healing, right? Once you got injured after a few days, okay, it starts getting healed out. So the body also needs to now break down that clot, right, which is formed over there, and also the body wants to remove it, right, just like the debris. All this process is known as means the breaking down of the clot and the removing of the clot after during the healing process, all this known to be as fibrinolysis. Fibrinolysis, right? Lysis means the breakdown. So the key enzyme in the fibrinolysis is actually plasmin. Okay, this is the key enzyme in the fibrinolysis. And plasmin, this is produced from one of the inactive precursor, which is known as the plasminogen. Okay, so plasminogen circulates in the blood and gets activated by the tissue plasminogen activator, right? This is to be known as the TPA, right? The tissue plasmino activator, okay, which is released from the damaged blood vessels. Once this tissue plasminogen activator is being activated, the plasmin acts like a pair of the molecular, just like the scissors, right? and it cuts the fibrin mesh and starts carrying it, right, all the mesh, and starts breaking down into the smaller degradation products. Okay, and once this plasmid is acting on this mesh, right, and that mesh is now being degraded into the different products, right, or into the smaller pieces, right, one of that breakdown product is D-dimer. One of that product is the D-dimer. Okay, so we have to now understand that let's connect to that or get back to that concept, that why do we need this D-dimer test to be ordered in the emergency department or anywhere in the hospital that I've told you. Okay, very first thing you have to remember it out, that this D-dimer test, this measures the level of the D-dimer fragments in our blood, right? The D-dimer fragments, okay, in the blood. Let's say that if we got the test to be done in the healthier person, so what is going to happen now? There will be very little D-dimers in the blood, right? Because there's no active clot formation and the breakdown happening. But when there is the active blood clot and that clot is being broken down, the level of D-dimer in the blood gets rises. Got this concept, right? So higher D levels, or higher D-dimer levels always and always indicate the clot formation and breakdown, which is actively occurring somewhere in the body. So it helps out to clinically, right, distinguish so many of the conditions like the venous thromboembolism, VTE. Okay, this is very, very helpful to detect the thromboembolism, right, VTE. Why is that? This venous thromboembolism is further gets divided into the deep vein thrombosis and also pulmonary embolism, as we have discussed that previously, right? So this deep vein thrombosis, what happens into that? We do have the clot, right? A blood clot into the deep veins, usually in the legs, okay? And in the pulmonary embolism, this is the blood clot, right, that has traveled from the leg and ultimately reached your lungs and blocks your pulmonary artery. Okay, so when a patient presents with the symptoms like the leg swelling, the leg pain, right, or sudden shortness of the breath, we usually suspect as doctors the DVT, right, or pulmonary embolism, right? And so the D-dimer test is usually used to screen out all of that one to check out whether the person is having the pulmonary embolism or DVT or not. Okay, so now just simply look out to some of the drugs we're being given out. These are the thrombolytic drugs and these are the anti-fibrinolytics drugs, right? The thrombolytic drugs, we do got to listed out the three of those ones, that is the alteplase, right, the retaplase and the tenecteplase, right? All these ones are the thrombolytics, means they enhance the function of this tissue plasminogen activator so that we do have more and more plasmids, right? But if you wanted to inhibit that, we do have the anti-fibrinolytic drugs, which is the aminocaproic acid and also the tranexamic acid being given over here, right? So these are very, very useful. Specifically, the anti-fibrinolytics are going to be useful when the bleeding is a problem and we want to preserve the clot, right? So we have to remember it all. One last question you can remember all, that why is D-dimer increased in the conditions like pulmonary embolism, right? This is usually been asked. So you can just simply tell them that because D-dimer is being produced when the cross-linked fibrin is broken down, right? Because this is the degradation, one of the degradation of the part. So if the body is forming and breaking down the clots, it means that the D-dimer will be more and more, as I've told you in the pulmonary embolism and the deep venous thrombosis. But do remember, yeah, this is the point to remember in the end of this session. Do remember it out that, do remember that the D-dimer, no doubt, is sensitive, okay? The test is sensitive but not specific. What does this mean? That of course, okay, if there will be any sort of the clot formation in the body ongoing, right, the D-dimer can detect that one and we can have the higher levels of the D-dimer. This is known as the D-dimer sensitivity. But not specificity means that it doesn't always mean that only and only in pulmonary embolism and only in the deep venous thrombosis it will be higher and not in any other conditions. Usually it is not specific to these two conditions. It can raise up into many other conditions like the ongoing infections, the inflammations, the pregnancy, the surgery, and the trauma-like conditions. Okay, so all this is about the coagulation and the kinin pathway. Once last concept that we need to also discuss, that is the hereditary angioedema. I've told you previously that we do guard the angioedema development if we do have the C1 esterase inhibitor deficiency, right? But what is the difference between simple angioedema and what is actually the hereditary angioedema, right? So do remember it out. This hereditary angioedema, this is actually a genetic disorder, right? And inherited as the autosomal dominant dominant pattern, right? So everybody got to know that, right? What is the autosomal dominancy means out, okay? And in both of them, do remember it out. If we do have the angioedema or the hereditary angioedema, right? We do have the functional deficiency of the C1 esterase inhibitors, okay? So we do have the several features to that one that we can discuss later on in the pathology, right? I hope that this is absolutely coverable, understandable by every one of you. Got any questions? Please do let me know.